Well, I want to start by thanking Aphasia Access, because this is a truly amazing 24-hour event, and I'm delighted to have been invited. I'm here in the UK, so it's about 11:15 in the morning. I'm trying not to be too bright-eyed and bushy-tailed, because I'm aware that many of you are joining 6:15, much earlier. You're going to need to pull up a chair, grab a cup of coffee, and let's wake up slowly with some lovely positive messages about storytelling in aphasia. So what I'll do is I'll share my slides and we can get started. So always best to start at the beginning, although I'm right at the end there, and I know Aura Kagan would be very happy that I was beginning with the end in mind there. But best to start with the first slide. So it's wonderful to have been invited to join this event. I want to use my time to talk about storytelling in aphasia. And I've got just over 40 minutes to take you through this. I'll try and pause at various points, but I'll pick up any questions you have at the end. So why storytelling, you might ask? At first glance, you might think, well, that's a really nice thing to do with somebody, really nice thing to work on, but perhaps it's a bit niche. But the point is that we're not talking about fictional storytelling. We're not talking about reading fairy tales to grandchildren. We're not talking about this specific fictional kind of storytelling. We're talking about something much broader. We're trying to aim for something much more functional and much more integral to life participation. So we're talking about storytelling in the broadest sense. So this might be a small personal anecdote that people tell. It might be a personal story that tells more about the person's identity or attitudes to something. What we're talking about with storytelling is everyday talk. And so we're talking about chunks of language, chunks of discourse, which are going to help at the language impairment level if we work on them. They're going to help people convey their personality, their feelings, their identity, and they're going to help people participate in life situations. And we know from Bronnie Davidson's work on communication activities that actually a good chunk of everyday talk are these kind of small aspects of storytelling. This is something that features in the everyday of talk of older people generally, but also people with aphasia. So if we as clinicians can work on personal storytelling with people with aphasia, then we're giving them more resources and more techniques to use in living with aphasia. So I'm presenting today on behalf of a bigger team, the LUNA team. So the principal investigators on the LUNA project are myself and Madeleine Cruz. We have a wider research team from across the globe. So Mary Boyle from the States, Deborah Hirsch from Australia, and then Jane Marshall and Nikki Botting from the UK. We've just recruited some new staff. So we have a project manager, Kate Swinburne, who many of you will know from aphasia assessment, the CAT and the AIQ. We have some new research therapists who are going to be helping on the LUNA project, Sarah, Gabriella and Richard, and we have some new research assessors, Carla and Lynn. So this is just part of the LUNA team. We also have advisory groups. So we have a group of clinicians who've been helping us in the UK to make sure our materials are going to work in clinical settings. So Suki, Nicole, Simon and Richard come from a range of clinical settings. Some work in the community, some work in hospitals, and they have a range of experience in working with people with aphasia. We have a second advisory team seen here. So these are our advisors with aphasia. So Lynn, Steve, Verinda and Jan. And again, they've been helping us make sure that we get our LUNA materials right. And you can see from this photo that our advisory group sessions are noisy, active, and full of things like donuts you can see in the table in the middle, but chat about the lunar materials, chat about what's going to work for people with aphasia, chat about why stories and storytelling are important for people with aphasia. So LUNA, what is it? You'll have guessed it's an acronym. It's an acronym that stands for Language Underpins Narrative in Aphasia. So what we're gunning for here with this treatment is to work on the language and the language strategies a person needs to improve their personal stories. So we focus on personal narratives. Sorry, I'm just going to move the screen slightly for myself. And these are the stories we tell about ourselves in everyday life. So when we're catching up with people, perhaps when we're meeting people for the first time, when we're reminiscing, when we're talking to our families, these are personal stories that tell something about our lives and who we are. And our aims for the LUNA project were to develop a feasible and acceptable new discourse treatment for people with aphasia that works on improving their personal stories, and crucially, that's feasible to deliver in clinical practice. So we've had to clip our wings along the way in order to create something that's not just theoretically wonderful, but that is actually going to work in everyday clinical practice. So you can't necessarily have all of the levels of assessment and treatment and all of the detail or the time that you might want if you're going to design a perfect treatment. You have to design it in a way that's going to be clinically feasible. So we've had that in mind from the very start. Now, why are we doing this? Why did we think discourse was an important thing to work on? Well, we know from research that improved everyday talking is an outcome desired by people with aphasia. And we know it's considered the endpoint goal of treatment by research trialists and other aphasia stakeholders. And everyday talking requires discourse skills. But as clinicians, you'll know that discourse is problematic to assess and to measure. There's an uncertain evidence base around it. And we know that if you treat at the word and sentence level, we know that that doesn't necessarily generalize to discourse. So we can't just stop there. We need to move forward and start working on discourse. So in LUNA, what we're trying to do is we're trying to support the 3 pillars of evidence-based practice. So those 3 pillars are research evidence, clinical expertise, and patient values. So in LUNA, we're trying to acknowledge patient values. We're trying to face those challenges inherent in the discourse evidence base and also inherent in what we know about clinical expertise and clinical barriers. So in terms of my talk today, what I want to do is tell you about what we've done in LUNA to support each of those pillars of the evidence base. So I'm going to start with a survey of clinical practice, which we've used to look at clinical expertise, and then I'm going to move on to the other 2 pillars. So first of all, then, our survey of clinical practice. This was about discourse assessment specifically, not assessment and treatment, so just assessment. We surveyed UK clinicians and we wanted to know what their views were and their reported practice in discourse analysis. We wanted to know what their views were about clinical feasibility, and we wanted to know what they perceived to be the barriers and facilitators to doing more discourse in clinic. There's a paper out from the LUNA project on this. The reference is there. You can access it online through the journal, the International Journal of Language and Communication Disorders. But if you don't have access, then you can go to the City Open Access Research Repository, and you can get it there after the embargo period. So you go to open access city.ac.uk. So this is a good tip to know. You can get any research from City University researchers there. So our survey looked at 211 UK clinicians, 94% of them were female. They came from a range of UK geographical areas, a range of work settings, hospital, community, and other settings. And the majority had at least 50% of clients with aphasia on their caseload. You can see the range of ages on the screen and the range of clinical aphasia experience. So we had a broad range of people. What did we find? What did these clinicians tell us? Well, first of all, about how they used discourse for assessment. About a third of them, well, 30% of them, said they usually or always use discourse, an aspect of discourse in their assessments. 37% of them use discourse assessment sometimes, and then 28% used it rarely and 4% never. So we had a split of about a third, a third, a third. We had our super users, our sometimes users, and our much less regular users of discourse analysis. And looking at these subgroups statistically, we found that what characterized those super users was that they largely had more experience, but that only accounted for 2% of the variance in the findings. Actually, other factors in making them super users were that they were motivated. They saw the reason for using discourse assessment. They saw how it impacted on the client's goals and the client's treatments and outcomes, and they had opportunities and support at work to look into ranges of ways to measure discourse. And what characterized our people using discourse assessment less often was their self-reported skills and knowledge, so their sense of their own capability. So there was some insecurity in a third of our respondents. So the headlines in the survey were that 95% of clinicians were just making clinical judgments about discourse. Only 16% conducted what they would think of as detailed analysis. And most of them followed no strict, so no protocol procedure. And the most popular thing for people to do was to manually count things, manually count words in a discourse or structures like sentences in a discourse. So what were the barriers to people doing more discourse analysis? You won't be surprised to hear time, lack of training, lack of resources and equipment, whether they had support in their workplace, and also client factors, whether they considered their patients too severe or for some other reason they didn't consider their clients needed work at the discourse level. Not having a set protocol was a huge barrier. Lack of expertise, lack of confidence. And there was also some negative emotion expressed around discourse assessments, that people found it confusing and frustrating. What helps? Those who truly considered discourse analysis as an integral part of the speech therapist, speech pathologist role did more of it. Those who could see that it was important in overall clinical management did more of it. And what would help in the future? People wanted more training in discourse analysis. They want more assistive tools, more time, more analytical tools. And you can see then that there is this huge need out there expressed by the UK clinicians. But how then do these findings compare with other surveys? So other surveys have been done internationally, but ours is the newest survey. So there was more reported use of discourse analysis in our survey than past papers, which were up to 10 years ago. So this seems to be an evolving field, and doing discourse in clinics seems to be something that's growing. The barriers, though, are the same. They're the same in those studies from 10 or more years ago, and the same in our study: time, training, confidence, skills, and knowledge. So what can we do? What are the implications for clinicians? We'd suggest that you buddy up for support, because support seems to be important. So find somebody else, another clinician that you know, who's doing discourse analysis, and work together. Or find a champion at work who's going to support you to spend a bit more time thinking about discourse analysis. Start small with one participant, try it out, see what it tells you, see how it informs your goals, see how it changes your therapeutic practice. Do a case study and share it with the team. And we recommend collecting discourse samples on at least 2 different discourse genres. There's evidence that points towards the importance of doing this. And we would say record it, or audio record it, transcribe it orthographically, because this helps you do the analysis. It's really, really hard to do the analysis just by listening. You can sign up to our Luna blog. I'll give you details later to find a support network. And there will be some City University Luna aphasia resources coming soon, and I'll give you more information at the end. So that's a snapshot about what we found in terms of clinical expertise in storytelling and in discourse more widely. We've also looked at research evidence in terms of discourse treatments. So what are clinicians doing, at least in treatment research, to treat storytelling and to treat discourse more broadly? So what we did was a systematic review of the evidence. We looked for existing discourse treatments. We described the interventions that we found. We looked at the quality of the design and the quality of the treatment reporting to see whether these studies were replicable. We looked at the outcome measures used, and we looked to see if the treatments themselves were effective. So again, there's a paper you can find that's currently published online in Aphasiology, if you can access it there, and if not, try the City University Open Access portal. I'll give you the headlines now though. The context that we found in terms of discourse treatments were that this was a low quality evidence base in terms of the treatment design. So there were very few randomized control studies and a lot of single cases. There was a moderate level of evidence in terms of the quality of reporting. There was an inconsistent pattern in which assessments were used, which means that you can't compare easily across treatments. There was an inconsistent use of stats, and there was very little assessment of treatment maintenance of gains. What we found was just 25 papers treating discourse and aphasia. We didn't have a time limit on the papers we were looking for. We looked across the whole of the evidence base. So this is a relatively small evidence base. It involves treatment involving 127 people with aphasia. They were mainly mild to moderate, and there were a high proportion of people with non-fluent aphasia. There was a range of times post-onset, but there was a bias towards more than 1 year. And for those that did use the WAB to measure aphasia quotient, this was 14 of the studies, participants ranged from 9.7 to 91. So that's a huge range, but usually it was between 50 and 70, so the mild to moderate aphasia range. Of those 25 studies, encouragingly 22 reported improvements post-treatment. However, 21 of those reporting improvement, the improvement was confined to single word production. So these were discourse treatment studies, but they were measuring treatment at various levels, and 21 of them found gains in words. 8 of them found gains in sentences, and 7 found gains in improved discourse macro structure. So you can think of this as the structure of the story. So the beginning, the middle, and the end of the story, and also how that story hangs together and the structure of what you find in those different parts of the story. But actually the main thing we found was that hiding under this title discourse treatments was a huge range of different discourse treatment methods. And we could actually categorize these into 6 different categories of treatment. So although we said when we were looking in the review, what we were looking for was treatments that were aimed at improving discourse production, actually when we scooped them up and looked at them in detail, there was lots of different therapeutic activity. So we looked in those papers for how they described their treatment, and we looked for explicit statements of cueing, correction, feedback, or scaffolding, things that we think of as therapeutic activity. And then we looked at where that kind of activity was happening. Was it happening in word level tasks or in discourse level tasks? And we found lots of different targets of treatment. So we found lots of papers targeting single words in the context of a discourse, targeting sentence level activities in the context of a discourse. And we also found other methods such as scripting, treatments targeting discourse macrostructure. We found a small group of studies that targeted more than one level of language. So multiple levels, 2 levels might be words and then discourse macrostructure, and 3 levels would be word and then sentence and then discourse macrostructure. And then we also found a couple of papers where we as a research team couldn't agree where the main therapeutic activity was, but it was definitely a treatment aimed at improving discourse. So this is just a breakdown of how many participants were involved in those different types of discourse treatment. And the stars indicate where we had a randomized controlled trial. So the purple stars are randomized controlled trials. We had one at sentence level and one at the multiple levels of word, sentence, discourse macrostructure. And then the pink star shows that we had a well structured quality group study also at that multiple level. You might recognize some of the treatment approaches that were being used to target discourse. So it wasn't that people were reinventing the wheel, they were using established, well understood treatments and repurposing them. So working in familiar ways and then providing opportunities for those methods to be practiced in a discourse context. And there were lots of different types of discourse being practiced and also assessed. So there was personal storytelling, but there were also other things like video retelling, picture sequences, and so on. So a wide range of discourse types. Now, were they effective? Well, the green ticks show that all of these types of discourse treatment resulted in word level gains. So it seems to be that no matter what kind of activity you use to target words, you'll get a word gain. These blue ticks were where we got sentence level gains. So here you can see that you have to specifically and explicitly target sentences in order to get a gain there. You can't just target words, practice in the discourse context, and then hope sentences will also improve, because those studies where the green ticks are on their own there show that that doesn't happen. If you target words and practice in the discourse context, you'll just get word level gains. And then the black ticks show where you've got improvements in discourse macrostructure itself, and these were the discourse and multi-level treatments that involved at least some discourse macrostructure therapeutic activity. So again, you have to explicitly treat sentences and discourse macrostructure to get any gains there. There was this huge variability in how people measured their outcomes, which results in this very messy chart, which I don't expect you to be able to read. I'll walk you through it. What it means is that there were multiple outcome measures in the evidence base, 500 plus incidents of measure use. For single word therapies, with then practice in the discourse context, the most commonly used outcome measure was words, so naming tasks or counts of words in discourse or counts of words errors in discourse. So this is why we found so much gain in the word level in this evidence base, was because a large majority of these treatments measured outcomes at the word level. The sentence, discourse, and script-based treatments were slightly different. They didn't measure naming on its own. What they looked at was measures of word improvement and sentence improvement extracted from discourse, and they looked at gains on aphasia batteries. And then the multi-level therapy used the widest range of outcome measures, which is to be expected because they targeted their treatment at more than one level, so they measured at more than one level. And the studies that reported gains at discourse macrostructure level, there weren't many of them. There was one discourse treatment and all of the multi-level treatments, but the script, sentence, and word focused discourse treatments didn't measure discourse macrostructure gains. So where does all of this leave us? Just going to have a quick look at the time. Okay. What it means in terms of treatment research is that we need more robustly planned research. And we need this research to employ high quality design. So we need more randomized controlled trials, more group level studies, and they need to be using stats, which is probably self-evident. But this is the way the evidence base in aphasia generally is moving to more well-designed, robust treatment studies. We need to be measuring outcomes across all three levels, and we need to be systematically using measures of maintenance. It would be really helpful if we could agree as a team of researchers looking at this area on which discourse outcome indicators we're going to use. And I know colleagues are very involved in this. Brill Stark, for one, is organising a team of researchers around this aim. So we need to agree a set of discourse outcome measures, but also perhaps a set of discourse types, discourse stimuli for use in assessment, and also to agree which standardised language and other measures we're going to be using to look at the impact of our discourse treatments. But crucially, we need to be intentionally treating all key linguistic levels that feed into discourse. So the word level, the sentence level, and the discourse macrostructure level, if we want to see gains there. What does it mean for clinicians? Well, this fact that word production improved across the board might be a message that you're getting from lots of sources. There's lots of robust evidence now that we can improve single word production for people with aphasia. This is something that we know and that we shouldn't be worried about anymore. We've got lots of methods for doing this. It's time to move forward and look for gains in other areas. But we don't have to throw away everything we know already. So improving the number and type of words that are being used in connected speech, in discourse, can be achieved with some slight adaptations of methods that we're already using. So we can do our standard word production treatments and then provide some sentence context for practicing them, or some discourse macrostructure context for practicing what we've learned at the word level. So it's about taking what we already do and just extending it a bit to provide opportunities for more gains. And then we need to look more at intentionally and explicitly treating sentence and macrostructure. So we need to be looking for new methods, or methods that we perhaps don't use as often to do this. So we need to be intentionally looking for sentence treatments and intentionally looking for macrostructure treatments. We found 10 studies in our discourse treatment review, which would offer some help here. Some of them are probably more useful than others because of their research design and the way they have reported. So I'd especially recommend 2 of them. So Anne Whitworth and team's randomized controlled trial Narnia is one of the multi-level treatment studies that's worth looking at. And Liz Hoover's group study involves treatment at more than one level by design, and it has measurement at more than one level, and so it shows these gains across word, sentence and discourse level treatment. So I'd highlight those 2 papers as places to start for clinicians if they want to look into this further. So the summary from our systematic review was that discourse is just beginning, it's emerging, starting to occupy a more prominent position in treatment research. We are beginning to move on from word level. And we're seeing this in 3 key ways. Discourse is featuring more as an outcome measure. And this is really important because it provides researchers of a way of measuring everyday talk or measuring language in more naturalistic context. So it's to be supported and applauded. Discourse is also starting to be used as the treatment context, at least in the 25 papers we've found. And so we can think that discourse is enlivening therapy because it's giving clinicians the chance to work with stories and other kinds of discourse. So picture description, storytelling, personal storytelling, riddles, fables, and other games. So it's providing a discourse context for our regular treatment activities. And then we're beginning to aim towards discourse macrostructure as a treatment goal, improving the structure and cohesion and coherence of stories themselves. But this area warrants a lot more attention in future treatment research. There's only tiny shoots showing here. We need to put more effort in. So the 3rd pillar then of evidence-based practice is patient values, and this is built into the LUNA project treatment design. So LUNA, we consider LUNA to be an innovative, creative and empowering approach to supporting people with aphasia to tell personal stories. We consider it an integrated treatment because it's integrating different levels of impairment research with things like personal values, personal opinions, personal interests, and identity. And also context for communication activities. Where am I going to tell my story? Because we start with somebody's personal story, we ask them first, what story do you want to tell? What story do you want to work on in treatment? And how do you want to work on it? This is a way of personalizing the therapy. So it helps make sure that the words and sentences and discourse structures that we're working on are the right ones. Because we know from treatment research that there's very little generalization. Mostly the message that comes from treatment research is what you work on, what you treat improves, and what you don't treat doesn't necessarily. There's very few indicators of generalization. So this means we have to choose what we treat really, really carefully. And it's not for us to choose, it's for the client with aphasia to choose. And one way to allow them to do that is to allow them to pick their personal story from the outset, and then to take the words and the sentences and the story itself and work on it. So by doing that, Luna provides this flexible tool for improving people's confidence and ability to express themselves, giving them macro-linguistic and macro-cognitive strategies and ways to get around difficulties and ways to construct their story in a way that they want to. And then that enables them to express themselves through their personal stories and reflect who they really are. So this is how we incorporate patient values into Luna. So we think of this as a kind of taking a part of something, taking a personal story that somebody brings to us that may or may not be perfect. I mean, nothing is perfect. So they bring us a story in whatever form it's in. We take it apart into its constituent parts, its words, its sentences, its discourse structures, its cohesion. And we work on each of those bits in turn. And we try out different things playfully with people. So here you use this kind of word. Let's think of some others that would fit there. Let's try them out. Do you like it? Do you not like it? Do you want to keep it? Do you want to keep this new word we've generated in your story? Okay, we'll put it in. And then doing the same thing with sentences and the same thing with discourse structures. So it's a playful approach to a client's language, and it's an empowering approach because we're giving people strategies to make those decisions themselves. And so when we've played around at all of these different levels, we encourage the person to put their story back together in a slightly different way, in a way that's going to look different from where we started from, and to try out telling that story in different everyday contexts. So take a bit of your story and try telling it to someone in an aphasia group, or take a bit of your story and try it out at the family dinner table. How did it go? What would help the listener? What would help you? Did you get the words you wanted? What would help? So it's about taking the story apart, building it back together, and then trying it out in different communication contexts. So we talked to our advisors with aphasia, and we asked them what their story goals would be. And we got lots of different ideas, and some of them were related to these impairment-based levels of language. So there were ideas like more colourful adjectives, bigger sentences, using the little words to connect sentences together. There were things that were about the bigger picture, the macro structure. So designing my story so it had a punchline, or to make it less boring, to make sure my listeners stayed listening to me for longer so that they got to the bit that I want them to get to. And lots of other ideas as well. And these ideas coalesced around our main Luna goals, which are to make a personal story richer, more meaningful, more complete, to make more sense and to flow more. And all of our impairment-based treatment activity is geared towards these goals. Where are we at? We're actually just recruiting now for the final phase of Luna, where we try out this newly built treatment, which we've designed with our co-designers. COVID-19 unsurprisingly stopped us in our tracks. We were just about to start recruitment when COVID-19 hit the UK. So we spent 12 weeks rethinking, adapting, planning, talking to our advisors, talking to our advisors with aphasia and our clinical advisors in particular about what we should do. We noted how clinical colleagues in the UK and internationally were adapting very quickly. They were embracing tele-rehab, and how swiftly and successfully voluntary sector groups were shifting online. And this teaching is an example of that, and how there were other support systems springing up immediately so that people weren't left isolated in lockdown. So we decided that we had to move Luna online. So we've moved it on the last stage of Luna entirely online. So we're going to be assessing people pre-treatment online. We're going to be treating them weekly online over Zoom, and we're going to be assessing them at the end over Zoom as well. Now, this final stage of Luna is a feasibility, fidelity and acceptability project which we hope will also yield some indicators for how effective it is. So what we'll know next year is whether it's feasible to recruit and retain people online to complete Luna. We'll find out whether the Luna methods are acceptable to people with aphasia, and also whether our assessment practice is acceptable to people with aphasia. We'll be using semi-structured interviews with them to do this. And we'll know something about the initial efficacy of the Luna treatment itself. We'll have a range of measures at language, so word level, sentence level, discourse macrostructure. We're going to look at communication participation, confidence, and aphasia-related quality of life. And we've got a waitlist control design, so we'll be able to compare our participants with those waiting for treatment. We're going to look at fidelity, so we've got 3 different therapists doing the Luna treatments over Zoom, and we're going to be able to look at whether they're all doing it in the same way, following our treatment manual. So you'll have to watch this space. You'll have to come back next year to see how we did. But in the meantime, we wanted Luna to be able to offer things to clinicians from the outset. We've had our eye on clinical feasibility, as I said, from the outset. We don't want you to have to wait to the end to start learning from the research that we've done so far. So we've spent some time creating some clinical resources, which will be available soon on our City Access Resources for Aphasia website. So the acronym for that is CARA, City Access Resources for Aphasia. And what we've provided there is a slide deck summary of the 2 papers I talked about, the survey paper and the systematic review. We're going to be providing some resources to support clinicians to start to change their clinical practice, to move away from single words to something broader. We're providing resources to support them in using discourse in goal setting, and also to support them in the assessments of words, sentence and discourse macrostructure, so that they can see whether the changes they're starting to make do have gains at all of these levels. And then after phase 5 of Luna, of course, we'll be hoping to share the Luna treatment in its entirety. So I've come to the end, and I'm hoping I've left some time for questions. Todd, have we got any?
Hi, Lucy. I'm
Hi,
not
Liz.
sure if... Thank you so very, very much for this talk. That was really terrific.
You're welcome.
Yeah, it's great stuff. I'm curious if, as I was listening through your talk, there's so many brilliant nuggets to take away, but is there just one thing, if you could boil it down, that you would hope that none of us would forget from all this great information?
You know, it's a challenge to pick one thing from this massive research, but I think what comes out of the systematic review loud and clear is that we have to explicitly and intentionally treat the things that we want to see gains in. So I highlighted the fact that you can't just treat words and then let somebody practice in the discourse context. You have to provide therapeutic activity at the other levels. But I'd go further, and I'd say that doesn't just mean the other linguistic levels. It means if you want somebody's communicative activity, if you want to see gains in communicative activities, you have to provide the resources for people to practice in different contexts. If you want to see gains in participation, something about your treatment has to be targeted towards participation. So one of the key things we have in our lunar treatment design. We have an hour's session with a therapist. We have an hour's practice with an assistant, and then we send people off with challenge tasks. And these challenge tasks are going to be so crucial to making sure the lunar games turn up in life. So we send them off and we say, you know, for example, watch a film online with a friend, and then talk about what you've seen, and use some of your word, sentence, and discourse strategies to shape what you're saying. So I think the message is you need to intentionally treat or intentionally give a context for the places where you want to see gains. We have to move on from single word treatments.
Well, I'm your choir here for that. So, Liz, can I ask you one quick question, because I don't see too many others coming in the feed I'm in. So sometimes I grapple with this individualizing the treatment and looking for an outcome that really matches the intention of the treatment and the core outcome sets or measures. How do you reconcile that difference in your work?
It's difficult. It's something we grappled with ourselves, and the solution we're taking is that we're using discourse as our main outcome measure. So we're using personal stories as our main outcome measure. So at the beginning of the lunar treatment, people will choose two personal stories, one of which we'll treat, but they'll tell them both at the beginning and they'll tell them both at the end. So we will also look at their untreated personal story for gains, to see if the gains have generalized from that one that we've been working on intensively for 10 weeks to another kind of story. So we've still got our main outcome measure there targeted to the content of our therapy, but we've got this whole battery of other assessments as well, some from the core outcome set and some not, but looking at other things. We've got a standardized language measure, we've got participation, quality of life, and so on. So I think it's probably the combination of both. The other thing about personalization, I think the take-home message about Luna is that personalization is a problem. You have to spend some time working out what is personal to a person for their language, and there are different ways to do it. You can ask them to keep a diary, you can ask them to come back with a list of words. There are various different routes in, and we've solved it by getting them to tell a story, doing the analysis on that story, and then coming back and saying to them things like, you use these kind of nouns, what else do you want to use? You use these kind of adjectives, should we add some more in? And taking personalization in terms of what's in that story itself. So it means that we need another personal story as an outcome measure, and that's very specific to the way we do it in Luna.
And can I ask really quickly how you measure those stories? Because presumably different people might have different goals within the discourse.
Yeah, so we've got, for everybody, we've got those overall Luna goals that I said about richer, more complete, etc. So what we'd have is a discourse indicator that matches each one of those Luna goals. People then have their own personalized goals. So to make my own story richer, what I want to do is use more adjectives, and somebody else might say, I want to use a greater range of adverbs or whatever. So how they make their story richer is slightly different, it's individualized, but we have a discourse indicator then that relates. So then we have this set of discourse indicators where we're looking at percentage of narrative words, we're looking at completeness of sentences, we're looking at reference chains, we're looking at discourse macro structure. So we've got one that maps on to each of the Luna goals.
That's great. Thank you. I apologize if I missed that detail in the story.
No. I had such a lot to cover.
Anyway, Lucy, thank you so much. I think I've hogged all the time that was left with you. We really appreciate you taking the time to share your work with us.
It's such a pleasure to be invited. Thank you so much.
Thank you. Take care.